Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we get to have the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and in today's episode, we're going to be exploring a topic that's really, truly transforming how we monitor and manage diabetes in dogs and cats. And that is, of course, the use of continuous glucose monitors, or CGMs. Some of you might already be using CGMs as a regular part of your toolkit, or it might be something that you and your team are just starting to consider. Either way, we're hopeful that this episode is going to help you better understand how these devices function, what their data can really tell us, and how do you put them on? How are we going to apply them step by step in clinical practice? So joining us today is returning guest, Dr. Tom Schermerhorn. Dr. Schermerhorn is a professor of small animal medicine at Kansas State University, and he's a leading researcher in veterinary endocrinology. He's got a particular focus in diabetes and metabolic disease. He's been on our program. It's been a few years now to talk about diabetes before, but we are super excited to have him back. And I just want to, hi, Dr. Schermerhorn, how are you doing today?
I'm well, Alyssa. Thank you. Thank you for having me back.
Absolutely. I'm so excited. Actually, the last time you were on the show, it was before I was hosting. So this is my first experience to have you on the show, and I'm truly excited about it. And I'm really excited to talk about this topic. This is something that I have just started to use in clinical practice myself, a couple of these monitors, and your article in Clinician's Brief was super helpful the last time I had to put one of these on. So before we jump into all my questions, if you could just take a second and let the audience know what you've been up to since the last time we talked to you.
Well, I am primarily a clinical veterinarian. I work with patients almost every day. But I do have a special interest in diabetes and in the management of diabetes, understanding the disease. And this is definitely a big part of it. As you alluded to, it's made a big difference in the way that we monitor our patients. I do want to throw out a shout out to the co-author of that article, Jose Estrada, who spent time with us as a resident here and has now moved on to a position at the University of Florida as a diabetes fellow. So he was mostly responsible for putting together all the nice photos that accompany that article.
Yeah, absolutely. I encourage everybody at home, we'll drop a link in, but go look at those photos because they are fantastic when you're going through this step by step on how to apply these monitors. We're probably going to talk a little bit more about that kind of after the break. To start off, I would love it if you could walk us through, how these monitors have, like you alluded to, kind of changed our overall approach to monitoring diabetics, especially compared with what I'm used to and what I was taught in school, which was that, glucose curve, bring them into the clinic, keep them all day, check their blood glucose every hour to 2 hours, and then send them home.
Well, that's really interesting because essentially the data we get from a CGM is a glucose curve. The difference is we've had a more or less as a profession, a love-hate relationship with the traditional blood glucose curve. And part of that was because you would have information that, one, the reliability was sometimes questionable, whether it actually reflected the situation at home was also questionable. And people did different things over the years to alleviate that, you know, um, that discomfort with the level of reliability. They taught people to do curves at home, but ultimately, what we were really seeking was some sort of profile of what insulin was doing in the patient. And with CGM, we've taken some of the reliability problems away. We've taken some of the accuracy problems away, but we've mostly added just an enormous amount of data that makes what we're seeing more representative of what we think is happening over the course of multiple days, not just the snapshot you get when you're in the clinic. You can kind of imagine if you went on a 2-week vacation and you had to show just one snapshot from that vacation that would summarize everything about it, you'd struggle, and it probably wouldn't be the right snapshot to tell everything about the vacation. If you had CGM, which is more or less almost minute by minute reflection of the 2 weeks prior to the data, you get a much better picture of what happened over those 2 weeks. So it's really added that level of reliability, accuracy, and gives us a lot more confidence in what we're trying to say about it.
Having said that, are there any like clinical situations or particular patients that you think CGMs are not appropriate for, or should we be kind of turning to these in every situation where we have a diabetic cat or dog?
Yeah, that's a great question. There's there's kind of two levels of validation for technology like this. The first one is, does it um, accurately reflect blood glucose? And so there's a validation steps that go with saying these values that you get from CGM associate or parallel very closely the the same values you'd get from another measure of glucose like glucometer or even chemistry measures. That's a level of kind of technical validation that the units do quite well with. Then there's also the kind of validation of, is this value as a surrogate for glucose um, helpful in the clinical situations, right? Can you always rely on it? And that hasn't been tested in all the scenarios that people use CGM. I think it has been looked at in dogs and cats as a diabetic monitor, but some of the other applications, like monitoring glucose in, say, an insulinoma patient, or monitoring glucose in a anesthetized patient, hasn't been looked at as rigorously. And while the technology may still function, the clinical validity of it, in terms of, can I make a decision based on this number that is supported by, you know, studied a studied situation, really isn't there for all of these things. So I would never say it's not uh, contraindicated in a particular situation, because it can always probably give you more information about glucose than you could have gotten easily in another way. But I would always look a little bit askance at some of the newer applications, because that's not what the monitor is necessarily meant to do, and it's not been studied in those situations. But as a monitor for a diabetic, um, I think it has a lot of promise, and people are obviously using it effectively.
You had said, really the one of the huge benefits these devices is their ability to collect, so much data and very frequently, frequent data points over days or weeks. Um, there are traditionally before we had these types of monitors, we relied on things like single fructosamine levels or spot glucose checks, and so do you ever employ those types of tests now, or are those really in the rearview mirror now for you?
No, again, I think, I think that's a great way to look at this. Is it's not supplanted everything else we ever knew about diabetes. There's still a role for patient history taking, patient monitoring, um, and understanding whether clinical signs are present. Um, this should only be looked at as complementary to those other things. Now, with respect to fructosamine, um, you could make a good argument that if you got a full 14-day um, profile of glycemia from a CGM sensor, that it kind of does replace the fructosamine, because that's roughly the window that fructosamine would tell you about. But some people do still continue to use fructosamine in their evaluations, and some folks might even consider adding something like A1C, which has a bigger retrospective window that goes beyond the lifetime of the sensor. So I think you have to kind of look at how you're using the CGM period. Are you using it as a continuous monitor? In other words, is the owner constantly replacing the sensors so that basically there's a sensor on the pet all the time? Or are you using it more as an intermittent monitoring tool, where every couple of months in a stable diabetic. You get them in for a 2-week sensor application. They go home, and then 2 weeks later, you look at what their data looks like. Um, that is, I think that has to be factored into how you use the data too. Continuous monitoring does have the dilemma of what do you do with all that data, and how much do you respond to the flags that are flying almost on a daily basis for some of these patients, whether high or low glucose. Um, you did say something that I just kind of wanted to touch on too, which is, in terms of integrating this data, um, we're still always looking at an average, right? I mean, what we fructosamine gives us an idea of the average glucose over the lifetime of the fructosamine protein, which is glycated albumin and others. So roughly a couple of weeks in dogs and cats to kind of, uh, just kind of lump them into one time frame. But the one thing that you can get from CGM that you don't get from any other measure is the actual dynamic response to insulin. So you can't get the pattern of glucose response following an insulin injection from fructosamine or A1C or spot glucose, or even clinical signs for that matter. Really, a glucose curve or some iteration of it is the only way that you can see what the insulin is doing in that patient over time. And previously we used old school glucose curves to change doses and things like that. We hope to get that information from a glucose curve, but with all the drawbacks, it wasn't super reliable snapshot level data. The CGM data does give you more confidence that the profile that you're seeing on average is what's happening over the course of the day. It gives you a more confidence in changing insulin dose, changing insulin type, making an assessment about what the insulin's doing.
Yeah. I think it's important, though, to remember that we as veterinarians need to be making that decision. So, what kind of communication strategies do you use to kind of prepare owners and to talk to owners that may want to jump in and interpret that information or get very alarmed if they see something on their monitor? Some of these systems have alarms, features. They alarm you for low sugar, high sugar, and they have cloud systems so you can share data. And with all of that information, sometimes I think that there's the potential for owners to maybe get ahead of us.
Yeah, yeah. I mean, you asked for communication strategy. I assume you mean effective communication strategies,
Yes.
um, because you can do a lot of talking about these systems with owners, and there is kind of almost like uh, a psychosis that goes along with having the ability to look at glucose very frequently. And I think some owners become very fixated on interrogating the unit fairly frequently over the course of the day. And you have to realize, and maybe we do as veterinarians, that this was happening whether we know it or not. Previously, we didn't know that there were periods of hyperglycemia during the day, and it didn't bother us that much if everything else was going well. And so I really try to get the owners off of one time or even alarms for hyperglycemia that go on for several hours. I mean, it's unreasonable to think that all animals are going to have completely acceptable glucose ranges throughout the day, and I really don't want them to get fixated on documenting every period of hyperglycemia. We're still looking for trends. We're still looking for averages when we look at these. So I guess my communication strategy regarding hyperglycemia is to expect it, um, and not to necessarily think that it's going to be associated immediately with a problem. Um, the units typically don't measure as high as some of our glucometers, so they will max out in a dog or a cat that's either just kind of newly becoming regulated or is dysregulated, and that freaks the owners out when the units are too high to read. But really, that's not necessarily a cause for immediate action. It tells you that you probably have to do something about it, but you don't have to do it in the middle of the night. You don't have to necessarily, have the owner just panic over that. Hypoglycemia is a different story. We're always worried about it when we're giving insulin, and the units are meant to alert people who use them in the human side or owners on the veterinary side to hypoglycemia. And almost all the manufacturers, I think all the manufacturers suggest that any alarm like hypoglycemia be confirmed with some other method. Usually they would have a human check their glucose with a glucometer, and we could have
Mhm.
some owners do the same. So, uh, you know, a, a regarding hypoglycemia, I guess my advice to the owners are when the alarm sounds, first of all, don't panic. If there's, kind of look at the patient, is there reasonable signs that it's clinically apparent that they're having a problem? If so, they should have a strategy already in place for treating that patient. We've already talked to them about that. If they can confirm it, that's great, but I don't have that as their primary goal. It's more assess the patient and treat if needed, um, if that's the case. But also, if there's no symptoms, they kind of need to look at maybe another reading in a few minutes, look at a trend. They can take steps to kind of feed the dog or cat or treat it and see what happens. And then let somebody know that it happened. But again, not necessarily every low blood sugar turns into, a trip to the emergency room. Um, they even as diabetic pet owners that aren't using CGM, they have to get comfortable with the idea of the possibility of hypoglycemia and managing that. And this is just part of that. So um, it doesn't work for everybody, and some have a maybe a greater need to get advice than others. But I do think just educating them to what to do rather than just react to the number. Um, the units are typically going to be more likely to flag a low glucose than not. So they have a bias towards reading low below a certain number, um, because the algorithm doesn't want to miss a low glucose and flag it as a normal glucose. So the machines are made to flag low blood sugars. That's why you need to confirm it. And so if that's really where I focus a lot of my communication efforts is on the low side, as well as the idea that my goal for giving an animal a CGM monitor is not to learn what to do with its insulin every day. It's to learn big picture, about what's happening over days rather than reacting minute to minute to what the glucose is. So I think you have to kind of, for folks who are maybe tuned into that from managing their own diabetes or managing the diabetes of someone they know, they have to give up a little control there, because the insulins that we're typically using are not meant to respond to those rapid changes in glucose. And so our kind of interventional day to day, minute to minute insulin adjustments are not going to work for most circumstances.
That makes a lot of sense. Kind of just expanding on that, for clinics that are using these monitors frequently, do you have suggestions for setting up kind of an action plan for the clinic so that they can sometimes or maintain some boundaries, especially if abnormal readings or alerts come in after hours? What kind of a system should a clinic have in place to make sure if there is an emergency like hypoglycemia that their clients get a response
Yeah.
or know where to go?
Yeah, I think that's really important. And part of it is to fulfill the kind of contract that you make with them. If you're going to use the CGM and you're kind of exposing the owners to these high values, low values that they can become aware of, um, you kind of owe it to them to make sure that they have an outlet for their anxiety and a plan for what might happen. You're asking them to monitor at home. We need to give them a plan about what to do if that monitoring tells them they have to do something. So again, I think part of that is setting up the conversation with the owner. I usually ask them to contact us if they have a concern of any sort. But obviously, at different times of the day and night, that's not going to be something that can be immediately attended to. So they have to kind of understand what's, a real red flag situation, like hypoglycemia or symptomatic hypoglycemia. I even have my owners call if they've treated them effectively at home. So if they've had an episode of hypoglycemia, they felt they had to do a treatment, and it worked, I still want to know about it, because I think that's um, probably something that would have to be looked into at some point, whether it be analyzing the CGM data or getting the pet back for some sort of uh, reevaluation. For high glucoses, again, I've kind of hopefully pre-educated them that high glucose doesn't necessarily mean a major problem. You know, dogs, cats are going to have good days and bad days as diabetics. Some days, whatever circumstances are in their life, they may run high for 12, 14 hours. You don't always find a reason for it. But if it were, again, a situation where it was unusual for the animal to have hyperglycemia, then they should let somebody know. But they've kind of been briefed on this isn't necessarily a major problem if there's no other signs that would suggest that the dog or cat is sick. So they're feeling well, they ate well, they just happen to be hyperglycemic. Um, or, the other thing that'll happen is that the units will start to give erratic results. It won't be reading, it'll give high, it'll give low, it'll kind of be all over the place. That's sometimes a sign of a failing sensor. And so the owners have to be kind of attuned to that too. If they're getting really crazy numbers that don't make sense for what they're seeing in front of them, they may have to just kind of think of, well, I might have to let somebody know about this, but I have to also, um, you know, potentially keep in mind that it's just not accurate reading. And for those owners that can check a glucose at home, then that would be the time to do that. Um, the one time I would have them reach out to a veterinarian as an emergency or as an urgent situation would be if they have documented hypoglycemia. Um, I don't want them to be on their own, so I will have them, call an emergency, uh, seek care, or call an emergency clinic to get advice. And in that case, I think you have to have a relationship with the emergency clinic. The, not every one of those patients needs to be rushed in to the emergency clinic, but they do need to talk to somebody who might be able to get them through a tough situation. And depending on your relationship with the emergency clinic, the comfort they have with managing these things over the phone, um, that may not be always the situation. A lot of clinics might want to see them, but that's something I think you just have to work out with the clinic that you might refer them to.
Yeah. That's where having that good communication between, who you're referring to comes into play, definitely. So we're going to take a quick break, and then we're going to come back and talk about kind of the process for applying these devices.
Sounds good.
Get the fast results your canine patients deserve. Think fast. Think Apoquel, oclacitinib tablet for allergic itch relief starting in as little as 4 hours. Visit apoquel.com for full prescribing information and to learn more. May cause worsening of existing parasitic skin infestations, serious infections, or pre-existing cancers. New neoplasias have been observed. Do not use in dogs under 12 months of age with serious infections or in breeding, pregnant, or lactating dogs. Think fast. Think Apoquel.
Yeah, so I, when I first started learning about these, I had all sorts of questions about, how do we even obtain these devices? Do they need a prescription? Are there any monitoring devices that are specific for animals, or are we actually, are all the commercially available CGMs that we're using designed for people? Can you tell us a little bit about those things?
Yeah, the technical side of this, they're fascinating technology, right? And they've been vetted in the general sense, through all the processes that need to happen for medical devices, um, but they haven't been necessarily made for animals, right? The majority of them. Some have. There's a unit I understand that's available. I haven't used it, um, and I haven't seen any data on it yet. But I've heard um, that there's one in development. I don't know enough about it even to give much information about manufacture and things like that at this point. But the ones we do have available, designed for humans, have been looked at in animals and been justified as being useful, giving a surrogate value that we can use to, assume what blood glucose is at the time. But I think your question was also about the technology behind these things changing a little bit, and they come and go. And actually, for the person trying to get into first using these, just trying to see what sensors are available, what will they still continue to be made? Is the technology changing? Um, the fact is, they are evolving quite quickly, and there's a lot of anecdotal information from veterinarians about, well, this iteration of the sensor doesn't work as well as the last iteration, but the data, a lot of the research hasn't caught up to that. Some of the initial studies were done with sensors and readers that were um, technology that was, kind of first generation or second generation, and now as they evolve, we haven't done new studies. The assumption is that they will behave relatively similar, and that's why we keep using the sensors. Um, but they do require a prescription, and um, the uh, the currently you can write a prescription for the sensor, and they can be refilled just like a normal prescription. But as sensors go away, patients that have a standing prescription may need a new prescription for the new sensor. So there's one particular unit that is about to change a lot of technology. At the end of September, current sensors will no longer be manufactured. You can use the available stock until they're expired, but eventually those patients would have to get a new prescription, for example. It's basically a medical device and requires a prescription. Um, the other confusing thing is, how do you read them? They all come with a reader, dedicated reader, which is a handheld electronic device linked to the sensor. But they also typically would be able to talk to a smartphone, and some of the confusion arises because they may be able to talk only to the smartphone or the reader, or they may be able to talk to the reader and the smartphone. And you have to understand which sensor you're using and what's possible. Because one thing that is uniformly unforgiving with these things is that if you um, goof up a sensor, you have to use a new one. Once the sensor's kind of out of the package and applied, and it's made an attempt to find a reader or a phone, if you haven't done that correctly, you're starting over. And depending on how you want to handle that, that means your owner's paying out of pocket for something um, that didn't work the first time, and now you're asking them to buy another sensor, and apply that within a few hours after they've just spent money on the first one. So getting good at it is important, and doing it, um, being familiar with it is important. Um, we've kind of found that certain people have a knack for putting on the sensors that others don't. And so we have identified folks who like to put them on, kind of take it as a challenge to get them on for 2 weeks and let those people go wild. But it's a good thing for one or two people in the practice to get familiar with, so that they can kind of develop whatever tricks that it takes to keep these sensors on animals where they're not designed to be.
Yeah. I think that that's the big thing. Like we said, these are almost exclusively designed for people.
Yes.
So obviously there's going to be some challenges in how they're applied, where they're applied, and then like you said, sensor loss, that's, a pretty common challenge and can be frustrating for owners if they're having to pay for a new sensor. Do you have any strategies for minimizing the chances of patients dislodging these? I know having somebody who's good at applying them, but do you use things like sweaters to cover them, or bandages when you apply? What are kind of some of your go-to strategies to help keep them in place?
Well, I think one thing we were all surprised at is the majority of animals remarkably will leave these things alone. Um, they are dislodgeable though, so for some animal trying to scratch itself or something like that could dislodge the sensor. And in that case, covering it with something that might prevent that is possible. Um, I think, what the steps we outline in the article kind of go through what works for most patients. The one thing that's different than just applying to human skin for a lot of techniques is to apply some sort of tissue glue or something to help adhere um, the adhesive pad on the sensor to haired skin or dehaired skin. Obviously the skin of the human is generally more smooth. It's a lot less dense with the hair, and so there's a lot more surface area for things to stick on. I think one of the biggest reasons for these things dislodging, in addition to just you know traumatic things that the pet may do to it, is actually hair growing under it, and which is one of the things that it seems to limit the sensor lifespan because it pushes the filament out of the skin and it loosens the whole thing up. And it's frequent, if you've had some experience with these too, when you go back after 10 days or 14 days and you see the sensors off the skin because the hair underneath has pushed it away, and that's one of the reasons that it'll fail. So getting a nice clean clip as best as you can on the skin helps at least delay that a little bit, if you can get as much of the little stubble off as possible. You also can do things like find the site that the pet seems to tolerate the easiest. Um, and but again, I think it's remarkable how often once they're on, they don't really bother with them. We also typically don't have the people groom them, or at least do bathing or anything like that. Not only is it likely to dislodge things, but it's an electronic device, so it's not going to be able to necessarily take those type of abuse. Um, and there's also you may have come across or heard anecdotally about the things being disabled by radiographs and things like that. Um, at least in theory, some of these sensors in the human side are meant to be able to be taught to go through radiation procedures, MR, CT, etc., and not be a problem. Um, I think in some of our situations, it could be that they're dislodged or they seem to be injured or disabled by the radiography just because they're dislodged during positioning or something. So we typically just take a lot of care when we do radiographs, and yes, we've had some fail after radiography, but again, I don't know that that's not something other than just damage by the um, X-ray machine. It seems potentially to be related to just positioning and dislodging that way too.
That makes sense. Can you talk a little bit about when we take the sensor off? So we've gotten the data that we want. We've decided that, or the sensor has become dislodged, and we're done. How should this be disposed of? Particularly, are there any environmental considerations that we should be aware of? Are there any parts that should be recycled?
Yeah, this is maybe a good time to mention something about the sensors. They have a 14-day lifespan for some of the more common ones, or the most frequently used ones. Um, I, I don't always expect 14 days, and I love close to 14 days. I'm happy with 7 days, and I honestly, if you think about what it's replacing in terms of old school glucose curve, if you get 3 or 4 days, it's probably worth the investment. Um, but yeah, taking it off, and you've seen these things, and maybe some of the listeners have seen these things. They come with a lot of packaging and a lot of plastic, and the applicator itself is quite a piece of technology. Um, and you wonder why it has to be so robust. But um, there, as far as I know, I don't know a lot about this, because it's when I've looked into it, it's there seems to be different kind of regional and maybe even international differences in what can be done with these things. There's a sites in the UK, for example, talk about recycling some of the sensors um, as a battery, where it can be cleaned and put into a electronics slash battery recycling type facility. I haven't necessarily seen that in the U.S., and I think there's a question as to whether it would be treated as a biohazard, because the filament at least has been exposed to patient tissue and blood and fluids. Um, the applicator itself, which is got more plastic in it than the sensor by far, um, has a needle in it, and so that might be potentially a sharps type disposal, which is how we do it currently. I also saw that at least one of the companies that make the most common CGM that we use in veterinary medicine has a kind of package up the applicators, and you can send them back, and then they are quote unquote recycled, because I don't know that the plastic's actually recycled. I think it's used in a different way, um, as a I think it's a waste to energy disposal, so it may have its own set of concerns. But I mean, currently, right now, we're not able to do a disposal situation. We treat the plastic as a sharp and the sensor as a biohazard.
Mhm. And then can you just talk a little bit about the difference? Because these are not actually measuring blood glucose, right? They're measuring interstitial glucose, and
Right.
there is a slight difference. So could you talk just a little bit to that, and whether that difference really has any impact on clinically, our decision making when adjusting insulin dosages?
Yeah, it's a really interesting thing, and I think the interstitial to blood glucose is definitely interesting from the standpoint of uh, understanding the disease and the glucose dynamics in a diabetic. Um, it has a really kind of narrow academic interest in that way. But for what most people would use this for is as a surrogate to tell you about what the blood glucose is. It kind of takes on a different connotation. In other words, we're saying, just like we use fructosamine as a surrogate for average glucose over 2 weeks, we're saying we know it's not the same thing as blood glucose, but we measure fructosamine and we use it in a way that tells us about the patient and the patient's history. The same can be said for this, although it's a lot more close in terms of being a surrogate. Um, you can also harken back to the initial discussions of using a glucometer, which originally in people was made for capillary glucose, but veterinarians quickly used venous glucose, and in some cases they
Mhm.
use serum. They spun samples and dropped serum on it, and they used it in that way to tell them about blood glucose. Um, and so they've always there's always kind of this, it's not the marker that you think it is, but is it a good enough surrogate that it's almost the same? And so one of the things that people did with the glucometer, for example, was to take the glucometer and then use it in an error grid analysis to say, am I making the same clinical decisions based on this information that I would make um, if I had the gold standard information, actual measurement of blood glucose? And for the most part, they were. There weren't that many really poor choices made on the basis of the surrogate. So the same could be, looked at this way. We look at this as an interstitial glucose, yes, but in most cases, it is reflecting um, close enough what the blood glucose looks like that the decisions we make based on it are probably going to be okay. Now, there might be some situations where that's not the case. A really rapid plummeting blood glucose might not be reflected in the interstitium for some lag period of time that in people can be estimated anywhere from 10 to 20 minutes, where that equilibrium has to reset itself between glucose in the blood, which we're interested in, because that's what's really going to cause clinical signs of hypoglycemia, versus glucose in the interstitial fluid, where it has to eventually cross cell membranes and other barriers to kind of equilibrate. So there are situations where the CGM might not reflect exactly what's happening in the blood glucose with blood glucose if it's changing really rapidly. But in terms of when we're looking at interstitial glucose clinically, most of the time, based on kind of what we think of as making clinical decisions based on the information, is probably going to be okay. So, I think that's partly why it's been useful so far as being a good clinical replacement for glucose curve, for spot glucose determination. It's giving us data that we never had before. It's giving us reliable data that we never had before. And it is functioning it's proving itself to be a good place to make clinical decisions from.
Yeah. And giving us oftentimes that information, in a home setting that's, much more common and consistent for what the animal goes through every day, as opposed to coming into the clinic. Because I
Yeah,
know
and I
that was
think and I
always.
think that reflects on the reliability of it, right?
Mm-hmm.
Because this is what we really want to know is exactly what's happening at home on the day-to-day, um, kind of life of our patient. But we also have to realize that every day is not the same with a diabetic. There are days where glucose is going to run high. There's days when glucose is going to run more in an acceptable range, and we're not able to predict those days because life is life. It changes from day to day. We want an average value. We used to try to rely on glucose curve for that, but that's not what it does very well. This does better. CGM does better with that. And when we're making a decision based on CGM, we're again aiming it at the average um, glycemia of our patient, not what it is today, not what it was yesterday, but average as best we can determine. And so, it functions in that way pretty well. And I think people are able to make not only more confident decisions about insulin, but potentially be, I don't necessarily use the word aggressive, but I mean, they usually make changes quicker. So a couple of days of CGM data, I feel a lot more confident making a insulin dose change, for example, than I would with just a single curve, um, because I'm already seeing a better idea of what looks like at home.
Then I guess the final question that I have for you before we wrap up would be, especially as we have a lot of discussion in the profession about spectrum of care, what does cost look like for this, especially compared to, how we more traditionally manage diabetes and doing these, blood glucose curves, which sometimes I was suggesting animals come in as frequently as every few weeks or once a month until we get them regulated. How do we feel like cost compares to, what we were doing before this was available?
Yeah, I like what you just said there, because I do think you have to look at it as not just the cost of the equipment, but you have to look at the bigger picture of, particularly in a diabetic, which is a chronic disease, even at the point of cost over lifetime of the patient, right? You could look at those things. And then there's also the cost that's less financial and more psychologic. If you can use this to get control quicker and have a happier owner and a safer patient, that cost might be justified. So I have not seen any economic analyses kind of to the conversation we just had. Um, but I think that's generally the approach I take when I explain it. I let the owners know that the cost of the reader, if they want to use the reader's one-time cost, the cost of the sensors are recurrent. But really, a sensor in our hospital, a sensor that lasts 2 weeks and provides really high quality data that allows us to make confident decisions. The cost of that is easily less than what it would be to do a recheck exam, a glucose curve in the hospital, and get data that is less reliable and that I have less confidence in is actually giving me the accurate situation. So, I do think when you talk about spectrum of care and integration of economics into care, diabetes is the perfect example in which that could be done, because these are typically, situations where the owner is going to provide 95% of the nursing care for the rest of the patient's life. Our role in it is relatively modest as veterinarians. And so we also have a great laboratory for actually doing the type of studies that we just talked about, is to look at traditional costs versus the cost of new technology. I don't know what it would come out to be, but my gut instinct, my gut feeling is that using the CGM is actually more cost efficient in the long run with terms of reducing the need for follow-up visits, using the resources more effectively for the owner, and maybe even giving better, you know, uh, confidence that we are giving the owner the best information we can, without having to do a lot of ancillary testing. So I find it really helpful to integrate into practice. And, I like to use it intermittently more so than continuously, because if a patient's doing well um, clinically, I don't know that this gives you that much more information. I'd more or less in that situation like to use it as a um, kind of a part of a periodic recheck. If you're seeing a stable diabetic 3 or 4 times a year, part of that could be a 2-week stint with the CGM, where you just say, yeah, it looks like this insulin regimen is still working for you.
Yeah, I would say that is absolutely how I have used it so far. My clients have been fairly accepting and kind of excited about the technology, although I haven't had one yet that's like, oh yeah, let's keep a sensor on my cat
Well,
all the time, 365
well,
days a year, which I'm glad about.
I would be glad about that as well. The some owners, I've had owners that though who have become the person who's good at putting a sensor on their dog or cat. Some people become very invested in this, and they uh, they watch it like they watch the stock market, minute to minute every day. And maybe it's just you know part of their mindset for managing this disease. But I think the continuous use can get a little distracting for some owners.
Yeah, absolutely. Well, Dr. Schermerhorn, that was the end of all my clinical questions. We do have one more quick little segment. We like to call it rapid fire. It's
Rapid
new
fire.
since the last time you've been on the show. And what this is it's just a series of quick would you rather questions. There's no right or wrong answer. This is just for fun. Would you like to
Okay.
play?
I
Okay.
guess so. Let's do it.
All right. Would you rather work up a case of polydipsia in a camel or polyphagia in an alligator?
I'll take the alligator.
Really?
Yes.
Even if it wants to eat you?
Well, I think so. Most
I think,
for reasons I won't go into here. It's
okay.
It stems from
Okay.
a previous um, professional problem that was presented to me, and I think it'd be kind of interesting.
All right. Well, if you were starting a clinic on a desert island, would you bring an ultrasound machine or would you bring a radiography unit?
Ultrasound, no doubt.
Ultrasound. Yeah. Ultrasound. Okay. If you had to switch specialties with a colleague for an entire month, would you rather be a surgeon or a behaviorist?
A month? I have skills in neither, so that's not a factor. I guess I would go with I'll go with surgery.
Go with surgery?
Yeah.
Excellent. I would go with surgery too. I actually really still enjoy surgery. Okay. Would you rather discover an insulin with 100% remission rate in diabetic cats or a diagnostic test with 100% sensitivity and specificity for Cushing's disease in dogs?
What? Uh, I'll go with insulin.
You'll go with the insulin? You're
I will
going to
go with
cure all the
insulin.
kitties? Okay.
Cure
Okay.
them?
Final.
Yes.
Yep. Final question. If you had to give an endocrinology lecture to either the investors on Shark Tank or the judges from the Great British Bake Off, who would you choose?
I would definitely go to the Bake Off crew.
I love those guys.
I want Hollywood and Prue to understand what they're doing to their customers.
Excellent. All right. Well, that was all my questions. That wasn't that bad, right?
That's not so bad.
Okay, excellent. I thank you again so much for coming on, sharing your insights and expertise on this evolving tool that we have for diabetes management. We will look for so much more in the future because, as you said, the technology is changing quickly. And thank you so much to our listeners for joining us. We hope you'll tune in next time for more conversations behind the content.
Well, thank you for having me. It's really it's been a pleasure, and it's good to meet you finally.
Yes, thank you so much. Thank you for listening to Clinicians Brief the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.